excited after attending the IDF meeting because I felt there was, such enormous energy. There was so much interconnectedness, and especially being held in Asia, I felt, there was so much synergism both between, the different parts of the world. I chose this particular theme, towards integrated care, old versus the new, um, because I just thought it touches on a lot of the key themes that were, talked about in the IDF. So, there was a lot of material to cover, but I've just selected a few talks. I guess we will, there was a lot of talk about obviously the newer medications, the SGLT2 inhibitors, the GLP-1 receptor agonists, in sort of particularly cardiorenal protection, and also insulin analogs. We just had the wonderful talk from Aaron Gafour about CGM and newer generation, sensors and excitement around the automated insulin delivery systems. Also precision medicine, particularly, genetics, multi-omics, and even sort of gut microbiota. But, with all this excitement of these new technologies going on in the background, we must not forget about, the traditional therapies, and how, the question is how we should integrate that to really achieve the best outcomes. So the first series of talks I would like to share was a session about the GLP-1 RA and SGLT2 inhibitors are on the front line, but can we afford it? I thought that was quite a thought-provoking session. So this is the latest IDF 2025 recommendations, and we could see here that, of course, lifestyle modification, metformin is still at the sort of the basics of therapy. But now, we are putting SGLT2 inhibitors, at much more in the forefront, both for people, with cardiorenal complications, and also as an option for even people with lower cardiorenal, risks. And of course, we see great movements in, having SGLT2 inhibitors available in even lower middle income countries. But even in places like Hong Kong, we are struggling to have access to SGLT2 inhibitors, across a broad population, both with and without diabetes. So I was going to share the talk by Rumpa Mehta from Mexico. And she shared a view about, whether the pendulums have shifted too far. Of course, in the UK PDS and other studies really, highlight the importance of, the legacy effect, the importance of early, glucose lowering, which will reduce both, micro and possibly macrovascular complications in the long run. But you could see here, as this is, enhanced data, and we could see that in the recent, 5 to 10 years or so, actually, we have, the glycemic control has not actually, improved despite the availability of more, better glucose lowering drugs. And we reflected whether this could be due to maybe system factors, clinical inertia, poor adherence, and at the same time, the use of these organ protective medications such as SGLT2 inhibitors or GLP-1 is still actually, rather low. So this is a very nice talk by Professor Fiona Chan from Hong Kong. And then she she reminded us of the difference between the old drugs versus new drugs. And she presented a network analysis of efficacy of 9 classes of glucose lowering drugs in RCT, settings. And you could see here, ranging from, drugs such as alpha glucosidase inhibitors, metformin to GLP-1s. Actually, most of them are good drugs. So, they can all show an average of lowering about, 0.7 to 0.8% in HbA1c. Even, amongst people on monotherapy and also on people on background, metformin therapy. And this also raises the point, what about those 70% of patients with no CV complications at baseline? Should we think about making access of, drugs that are may possibly, more older, just established, which are more affordable? So that was quite a, thought-provoking comment. And again, she also presented some real-world data from, this is from Denmark, from a nationwide register. And you could see that about 50% of patients treated with a GLP-1 receptor agonist or SGLT2 inhibitor actually discontinued their treatment, within 3 years. And only approximately half of them had treatment reinstituted. So, I mean, I think this pattern is also reflected in many parts of the world. And I wonder whether, locally you also experience a certain similar trend. And for us, even in Hong Kong, it's not to do with affordability, but also possibly due to tolerability and also maybe supply issues. So again, that is something that, we ought to reflect on. And finally, in that session, Dr. Warundi from Thailand, from the HITAP, so she shared a very important perspective on the cost effectiveness of GLP-1 RA and SGLT2. And again, I think it's raises a very important point. When how we can negotiate affordable pricing and equitable access to these drugs. And again, I think we need to think about the data evidence, which needs to be context specific, and also important to evaluate and monitor the cost effectiveness in real world. So she shared some examples of the economic valuation of, for example, a range of drugs that to be included in the Thai benefit package, and she showed that using cost-effective analysis, certain drugs can undergo price negotiation and to make it make the access possibly pricing more affordable. And also, she shared some studies where they looked at SGLT2 inhibitors in real world population. And again, this is a cycle that ought to be maybe a tool that can help help policymakers make better decisions with regards to drugs that are also maybe in future coming along, such as the future dual or triple agonists of GLP-1 RA based therapies. So the other session I would like to share is one we participated in together with other colleagues, Sunny Wong from Singapore and also Aram, who spoke just now. So the topic of that session was diabetes care, tradition meets science. So I, highlighted that, despite these newer exciting drugs and tech available, a lot of people are still using what we call complementary and alternative medicine, CAM. And in some surveys, I mean, approximately 50% people with diabetes said they have used some form of, say, CAM at some point in their treatment. And I think it's important to think about how we can actually integrate both conventional medicine and CAM using an evidence-based approach. So I mean, I covered the sort of several key classes of CAM therapies. So for example, herbal drugs. Here we cite example of berberine, which has been used as part of traditional Chinese medicines for a long time. Other drugs such as fenugreek, bitter gourd, that a lot of people with diabetes might take in other parts of Asia. Supplements, which has really been an exploding market, and especially, for example, magnesium or selenium, that has possibly got more evidence base in maybe helping with diabetes and other related complications. I highlighted the importance of, for example, mind-body therapies, yoga, that has really potential to improve holistic health. And also, Dr. Sunny Wong highlighted, the increasing use and popularity of prebiotics and probiotics and modulation of the gut biota, which again might be helpful in management of diabetes. And also, in the IDF sessions, we heard a lot about tech and also AI. So I attended the really fantastic talk by Amit Day, where he really highlighted, the potential role of AI in future, both in clinical decision making and also maybe predictive analytics. So, I mean, I think there are probably more established AI tools that are available, such as the retinal screening. But I mean, I think what is more of the unknown is use of AI in clinical decision support. So, for example, using AI chatbots, whether we can use this to enhance medication adherence, whether this can actually maybe reduce the education gap and enable access to more specialized care. So I think in general, the field is moving much faster than our physicians or systems are able to grasp. So, and again, I think this is a very important topic that we should hopefully revisit in the next big IDF meeting. So finally, I mean, Aaron Gafor really highlighted the importance of the view of people with diabetes. So, I mean, I agree. I think most of the people we look after fall into several camps. So we have people who are more comfortable with more traditional approaches. So they're much more, akin or feel comfortable with natural remedies. And they often have, concerns about medication side effects. And on the other camp, we have some science and technology advocates. They're willing to embrace and try something new, whether it's CGM or pumps. But again, they have sometimes concerns about the cost and also the complexity and potential burden of using these technologies. So on the whole, I mean, I think, we have to think about how we can adopt a balanced approach. And we had a great panel discussion together with the audience and discussing sometimes how, the views of HCPs may actually conflict with people's views of diabetes, how we should handle that. I think Mohammed Hassan really sort of illustrated a very good example, and I think it's using the example of the IDF and DAR, the risk application to advise people, how they should monitor or manage their diabetes during Ramadan. And I think we should future approaches really to take into account of both views of people and how we can best embrace these technology in a person-centered manner. So, I mean, I think there are lots of future challenges in integrative care. I mean, how can we evaluate these CAMs in a scientific manner? For example, lots of TCMs have multiple components, and whether we can utilize more complex analytical tools to enhance quality control. And I gave an example, for example, in Hong Kong. So we have now adopted integrative care clinics where Chinese medical practitioners also work alongside Western doctors, and our Chinese medicine hospital is about to be launched. So again, I think these are lots of potential solutions that we can think about implementing in Asia in future. But I think the final and the most important point is the access and equity issue. There was a fantastic panel discussion with representation of different parts of the world, and I think what are the global disparities due to? I think some of it is due to socioeconomic factors, but I think most important, to me, is the human resource. So the need and to have trained, dedicated medical staff, which is key to helping us implement the technology and solutions. And having the political will and engaging people with diabetes to really together advocate for better access to both medications and tech. And in fact, this was what I've been translating when I came back to Hong Kong. So in the next week, we still don't have CGM reimbursed in Hong Kong. So next week, together with some NGOs, Professor Ronald Ma and others, we are going to launch our first technology forum, a multi-stakeholder meeting to try to really find a pathway to getting CGM and pump access in Hong Kong. And also, we are, believe it or not, the majority of patients in Hong Kong are still on some NPH human insulins. And again, affordability of these essential medicines is a key, really across the whole of Asia. So I'd just like to end on a quote actually I borrowed from Aaron Gafor. So I think the key towards integrated care is really combining old wisdom and innovation, and how we can really find the best path forward for helping people self-manage their condition. So thank you. And if I don't mind, I would also like to take this opportunity as for a quick advert. We are holding our annual East Meets West Symposium in Hong Kong at the end of September. So this is a meeting where we'll be covering lots of important topics such as diabetes prevention. We'll be talking about newer generation CGMs, and we've invited speakers from many parts of the world. And there is also a young investigator travel grant and a young abstract competition. So everybody is very welcome to attend. So this is a QR code, and hope we could maybe see you, many of you in Hong Kong sometime in the future. So thank you very much.